Hello and welcome to South East London, London's Primary Care Cancer webinar series. Today's webinar is on what makes a good quality referral. I'm Zara Gross and I'm the Early Diagnosis Lead in South East London Cancer Alliance, and I'm joined by three panellists. We've got Dr. Caroline Hollington, she's the GP Cancer Lead in Greenwich, Dr. George Pavey, Lambeth GP Cancer Lead, and Harriet Watson, who's a consultant nurse and endoscopist at Guy's and St Thomas's. So I've just got a couple of housekeeping bits and bobs to go through before we kick off with the main presentations. So everyone is muted and your cameras are off by default to ensure clear communications and privacy. We are recording today's webinar and we will be uploading that to our YouTube channel, where all of the other webinars that have taken place in this series have been uploaded. If you have any questions, please click the Q&A button, which is on the bottom of the window. If you'd like to discuss anything with audio or video, then please indicate this when you ask your question. We'll cover questions either during the relevant section or at the end of the webinar. If there are any questions that we can't answer because we run out of time, we will take those offline and then share those with you. And we will have a certificate of attendance that will be sent to you all following the completion of the evaluation form, which is a quick form. It will probably take about a couple of minutes to complete, and then you'll receive the evaluation form. So I'm just going to pass over to Caroline and George, who will be leading on the primary care side on what makes a good quality referral in primary care. Caroline, over to you.
Thank you very much, Sarah. Hello, everybody. I'm Caroline Hollington. I'm a GP working in Greenwich, and I'm just going to give a starting sort of overview about some things that we could be thinking about from a primary care point of view when we're wanting to make referrals for suspected cancer patients. First slide, please, Sarah. And I guess what I want to say first of all is that it may be to some of you that what I'm going to say seems really obvious and really basic, and I apologise for that, but also I would just point out that the things we're talking about today are things that are repeatedly brought to our attention by our secondary care colleagues as things that perhaps sometimes in primary care we could improve on, and they're things that really, if we don't get right at the point of a referral, can make a really big difference to how quickly a patient's seen. Are they seen on the correct pathway or by the right person? So guidelines. I guess we all know and are aware of the NG12 suspected cancer guidelines that came out a number of years ago. They were interesting and exciting for a number of reasons. Number one, they were really looking to try and improve the early diagnosis of cancers. So we're really looking to reduce that positive predictive value for symptoms. But also they were the first set of cancer guidelines that were based on primary care research, so how patients actually present to us. And they've recently been reviewed by NICE, as they do with all their guidelines, and no major changes have been made. So we are on the right path with them. And then, given we all work in London, we are using the Pan-London guidance, which is based on NICE, but with some subtle changes because we have a unique demographic in London, and mostly the changes were around age differences. And then, of course, over the past 6-7 months, COVID's come along and has completely changed the landscape of how we're all working in primary and secondary care, and has brought about a unique set of challenges in terms of getting patients in to see us and getting patients referred on. And we've seen some changes to particular pathways, and I know we're going to speak about colorectal a bit later on, but colorectal, breast and lung, there's been some small changes that you should all be aware of. And I guess just to say about guidelines, they're great and they're really helpful, but what also is really, really important is the GP gut instinct, and that we never ignore that. If we get that feeling about a patient, we should act on it. And you may well have seen recently there was another study presented saying that actually GP gut instinct is as good as and probably better than some of the other symptoms that we're asked to refer patients on a 2-week wait referral. So if you get that feeling, act on it and don't be scared to act on it. And there's not been many positives of COVID, but for me, certainly one of the positives I found has been we've been able to get advice from our secondary care colleagues a bit easier, either through Consultant Connect or advice and guidance. And I'm really hopeful that that will be one of the things that will carry on post-COVID in a positive way for us all. And just to sort of say a couple of things that you'll see on the slides, just some places that if you're ever thinking, I'm not quite sure what the most recent guidance is, there's lots of places you can look for that. So there's the Healthy London Partnership website that has all the most up-to-date guidance and forms, and also the South East London CCG GP COVID clinical support page. If you can find it, it's actually really helpful. Got loads and loads of advice, not just about cancer, but certainly as the lead GPs across South East London, we've been getting together thinking what's going to be really helpful for our colleagues to be able to quickly access. So if you've not had a look at that website and you happen to have a spare 5 minutes, which I'm sure you don't, please go on there and have a little peek. Next slide, please, Lara. So the referral forms. If you're anything like me, you'll probably feel like you've been absolutely comms, email, overload, and actually it's really hard to keep up to date and make sure you read every single attachment of every single form. And sometimes when referral forms have changed in the past, practices haven't actually been up to date with the referral form. So in Greenwich, we use a system called DXS. I think there's similar ones used across South East London. Basically, it's a central repository where the referral forms will actually be updated for you. So you won't have to get your own IT admin team to update forms. And you'll know you're always using the most up-to-date guidance and forms. And I think we've just attached on the slide the 3 main forms that there have been changes to during COVID. So the colorectal, breast and lung form. And then one of the other pieces of work we've been working really hard on with the team across the Alliance is just to try and, as I say, because of information overload, try and put down in a really nice, simple algorithm what some of the changes have been to those big tumour groups. And again, that's available on the South East London CCG COVID website. Thank you, Sarah. So if we just drill down now into the actual forms, and again, please forgive me if you think I'm telling you really basic information, but almost every other meeting I go to as a GP with secondary care, I'm getting asked to, please can you tell your GPs to do this, please can you tell your GPs to do this, and it's even more important at the moment because we're trying to turn around cases really quickly. Quite often patients actually aren't going to a physical face-to-face appointment, they're having a telephone appointment, and if secondary care don't have this information, it makes it much more difficult for them to contact patients quickly and make sure they're seen in the best pathway. So, number one, are your patients' contact details up to date? I mean, loads of my patients seem to change their mobile numbers every few months. So for me, it's just one of those things I trigger as I'm making that referral. Can I check, is this your correct mobile number? Do they need an interpreter? Obviously, that's really important information for secondary care, and what language do they need? If secondary care know that information, they can make sure they act on it. But if they don't know it, then of course that's going to create a big delay in them being able to assess a patient. Again, carers' details and contact numbers, and actually putting on the form if the patient would rather that you contacted the carer in the first instance, that can be really helpful too. And one point that I actually just learned for myself as we were preparing this, the slides here, is about practice bypass numbers. And I must admit, I've never even realised that this appeared on the 2-week wait referral forms. Now, most of the information on this front sheet is pulled across automatically from GP records. However, the practice bypass number doesn't seem to be pulled across. So that's something that you may need to enter manually, or see if you've got someone very clever that does IT in your own practice, and they can make sure that's pulled across. And again, this is something that secondary care clinicians ask for again and again. They may just want to have a quick check with a GP to consultant to talk about the patient, or it could be an admin team want to get through and really quickly check something about the patient. If they've got a bypass number, that just makes life so much easier for them. So moving on to one of the updates that have happened since COVID, and you'll see that these things appear in red on the referral form. So information about the COVID status of the patient. Now, my understanding that this is actually whether you think a patient is very high risk, very clinically vulnerable if they were to be exposed to COVID. And again, that's important information for secondary care to know, so that when they're having those initial telephone consultations with patients, they can, you know, come to a decision with the patient. Actually, could we delay this for a while, or do we need to get this patient in now? And also they'll sort of understand a bit more about why patients might feel particularly anxious about going to appointments or having tests done. Next few bits about the form, I'm not going to say a huge amount about because George is going to talk about them. But I guess, you know, yes, you need to tick a box on the form to say why you want the patient to be seen. I'll come on a bit more to actually what else you might want to say. The box that I think's interesting and not to forget on this form is the box right down the bottom. So actually those groups of patients where they don't fit neatly into a criteria for a 2-week wait referral, but perhaps you've got that gut instinct, perhaps you just think there's something going on with this patient, please use that box. It's, you know, that's what it's there for. But what I will say as we go on to the next set of slides, Zara, is if you tick that box, you need to actually let secondary care know what it is that you're worried about. So just ticking that box and nothing else isn't very helpful. And I tend to use the box that says additional clinical information, and I quite often copy and paste my consultation into that box, so secondary care can really get a feel or a flavour for what it is that I'm worried about. You know, I'm worried this patient is losing weight. This patient just doesn't look right to me. I've got, you know, a strong gut instinct, something's wrong with the patient. And then coming back up to the top box, so the WHO performance score. I must admit, when I first saw this appear, and I started to sort of panic thinking, well, I don't know how to do a performance score and I don't know what this is all about. But actually when you read the box, it pretty much does it for you, and you don't need to be 100% accurate, but secondary care really need to know, particularly because some of these patients, they're not seeing face to face, they're just speaking to over a phone. Is this patient going to actually be fit enough to come to hospital, to have a colonoscopy, to have a cystoscopy? So we really need to be helping our secondary care colleagues and at least giving them an idea as to what sort of management decisions they might come to. Now, next set in the box is about making sure that you've told the patient about they're being referred on a suspected cancer pathway. Again, I'm not going to say too much about that because George is going to discuss that. What I would just highlight was the box where you tick to say the patient's been advised that they'll be contacted by secondary care by telephone. And what I always say to my patients at this point is, so please keep your phone by you over the next few days. And I also say to patients that the phone call might come from an unknown number. I know that when we phone our patients from our practice, it comes up as an unknown number. And certainly when I get unknown numbers on my mobile, I think it's someone trying to sell me something, so I sometimes don't answer the phone. So I think just sort of saying to patients, the hospital are going to be in contact by phone, and this might be over the next week, actually, you do need to answer every time your phone rings. And then coming down to the bottom bit of the box, again, I'm not going to say too much about this because this is just about making sure that you enclose with the form the most recent, relevant, up-to-date investigations and blood tests, or if In Greenwich at the moment, we have a real problem with ordering blood tests, so there's probably a 2 to 3 week wait for patients to have primary care blood testing done. But if you put that information on the form, so I've requested blood test, there's a 2 to 3 week wait, at least secondary care have a chance, once they've read that form, to think, actually, do you know what, we're going to get the patient in and get the bloods done from a secondary care side. But as I say, I'm not going to say too much because I don't want to steal George's thunder. And I think that's my last slide.
Great, thank you very much, Caroline. Thanks, Zara. My name's George Pavey. I'm a GP in Lambeth, and I'm one of the Macmillan GPs and cancer clinical leads in South East London, and work closely with the Alliance and Caroline, obviously. So I think the next thing that I wanted to talk about when we think about making a good quality kind of cancer referral is, as Caroline alluded to in her slides, is the importance of ensuring that those diagnostics that we are able to order are arranged kind of appropriately in good times, so that the cancer referral isn't held up in any way. Now, we know that if the referral is incomplete for whatever reason, including the lack of relevant blood tests, for example, that can lead to delays in diagnosis potentially, because the patient may not get the appropriate diagnostic tests in secondary care in a timely fashion. I also wanted to stress that, other than the demographic points that Caroline had discussed, but I also include in that extra kind of clinical information box any relevant comorbidities that the patient might have that might impact on secondary care's investigation of them. So things like diabetes, for example, which might be important for the secondary care team to know about. I also like to mention things like medications that might have a bearing on kind of invasive investigations. So anticoagulants, particularly if patients are going to end up having endoscopies or biopsies of any type. And also potentially any issues regarding kind of the patient's ability to consent to investigations and treatment. So there's no particular specific box necessarily, but I think it's always useful for the hospital team to know about any potential problems with the patient's ability to consent, just so they've got that information in early on in the referral process. So going back to blood tests, I think recent renal function obviously is important to make sure is included in the referral. Ideally, it has to be done within the last 3 months for the hospital to deem it relevant. However, don't let this delay your referral, because obviously waiting for a renal function to come back, especially if phlebotomy services are currently under a lot of pressure, as Caroline suggested, may end up in potential delays to that patient being diagnosed with cancer, and also just adds another potential step for that patient to be lost along the referral pathway. So I would suggest that you should order the investigations concurrently with the referral, unless you're expecting there to be a big problem with the renal function. I don't think it should lead to a delay. The other thing that can happen, and I know has happened in my experience of using EMIS and DXS forms, is potentially the blood tests don't populate onto the forms, and that can sometimes be a patient-to-patient problem, not happening all the time. So it's always useful just to double check in those investigation boxes at the bottom of the form that the recent renal function, full blood count, fit tests, and things like that have been pulled across, and that those boxes are populated. I suppose the other big investigation that we think about in primary care that we would readily order prior to two-week referral would be a chest X-ray. So just to ensure that an urgent chest X-ray, ideally within 2 weeks, is ordered for suspected lung cancer, and also to make sure that those patients have usinase, particularly because they may get directed straight to a CT thorax after the 2-week wait form has been triaged by a secondary care clinician, and if they haven't got that, they won't be able to have their CT thorax. I suppose, bearing in mind that we are aware that there is a high false negative rate with chest x-rays, so we know that they don't always detect lung cancers in about 20% of cases. So again, that kind of gut feeling that Caroline was alluding to is really important in suspected lung cancer patients, and don't just file a normal chest x-ray and leave it there. Go back, revisit the patient's notes. Hopefully they'll have been safety netted appropriately, and you can still explore whether those patient symptoms are still persisting. And if you are worried, or you still think there's a possibility of lung cancer even with a normal chest x-ray, then you should obviously proceed with a suspected lung cancer referral. I think another thing to think about is the recognition of lung cancer, particularly in COVID times, and that often patients that are most at risk for lung cancer are also the patients who are also very susceptible to significant COVID infections. And these patients are being managed remotely a lot of the time, obviously due to the current restrictions in seeing patients kind of face to face with potential COVID infections. But I think we need to be aware that because there is such a large crossover with patients who are susceptible to COVID and also may have lung cancer, that we need to think cancer in patients that have had symptoms, respiratory symptoms that are prolonged. And there is some guidance to suggest that if symptoms are persisting for longer than 3 weeks, then an infective course is less and less likely, and potentially a malignant process is more and more likely. So just to not label things as COVID for too long. There is some really good guidance around the recognition of lung cancer in times of COVID, and CR UK, Cancer Research UK, have produced some really helpful guidance for GPs, which I think we could probably make available or is readily available online. And there's also the recognition of lung cancer in COVID document on the SCL CCG cancer page. So I thank you, Zara, for nodding. Yes, so there's also our local guidance as well. So that would be really useful to look at if you do have a patient you're worried about. Next slide, please, Zara. Just talking a little bit about referrals to our rapid access diagnostic clinic, which is obviously a clinic for patients who don't fulfill necessarily criteria for other 2-week wait pathways, but there is still a concern of underlying malignancy. Now, I'm not going to go over the referral criteria for the clinic because I'm sure everyone is aware of those, and they are available on the RDC's website. But I did want to talk a little bit about the diagnostics around making a referral to the RDC, and just making sure that those are carried out prior to the referral going in. They are more extensive than with other 2-week wait pathway referrals, obviously, because we're trying to search for the primary. But so I've listed them there. I won't go through them all, but just make sure that they've all been completed. I think the abdominal symptom ones there may be less known to GPs, so it's just making yourself familiar with those. And I think also the statement about ordering urgent ultrasonography in a timely fashion, if that is possible locally, then I think that's appropriate to be done in primary care. If it's going to take a long time to get an urgent pelvic ultrasound, for example, then that shouldn't necessarily hold up your referral into the RDC, but it is there as a potential investigation that could be carried out. Currently, the Rapid Access Diagnostic Clinic is recommending that GPs contact the clinic either by advice and guidance on ERS or by calling the direct line to speak to their clinician in clinic, details of which are on the GST RDC website. And then they can either guide on an interim management plan, or discuss the potential diagnoses with you, or they can say whether a referral is appropriate or not into them. So it's always useful to contact them, particularly now as they are carrying a lot of their initial assessments out over the telephone. So it's good to make sure that they feel it's an appropriate case for them to be seen. I think, next slide, please, Zara. Yes, so just before I talk about the relevant information that can be given to patients prior to their 2-week referral, I just wanted to touch on safety netting of patients, which I know is obviously something that I'm sure GPs will be interested to talk about, particularly as it's such a big part of reviewing referral quality in regards to the new PCN-DES specification. We're not going to cover it specifically today, but be reassured that the next webinar in this series on the 12th of November between 1 and 2 p.m. is around a safety netting specifically, and that will kind of fulfill that kind of part of the PCN-DES spec around reviewing quality of referrals. So that will be covered at the next kind of webinar session. So moving on to patient information and communications with patients prior to their referral into the hospital. We know it's really important to inform patients about the nature of their urgent suspected cancer referral. We know that patients who are not adequately informed. Have I missed a slide, Zara? Sorry. Yes, thank you.
Sorry, George, that was me. I was too click happy.
So yes, we know that that patients who aren't adequately informed about the nature of an urgent cancer referral, we know that about 40% of patients, this was in a study a few years ago, weren't told that their referral was for suspected cancer, and that about just over a third of those weren't given any information prior to their referral. I often will ask my colleagues in surgery here not to call it a 2-week wait referral. That doesn't mean anything to patients, but being open that it's a suspected cancer referral and that's what they're getting referred for. I often will talk about, you know, they will see potentially cancer specialists, cancer nurse specialists, they'll be going, you know, so being very open about the fact that it's a referral to rule out cancer. But I also offer reassurance to patients that the majority of people that go to these clinics are not diagnosed with cancer, and it's a rule out service. So, you know, you can state percentages if you want. I often will say between 5 and 8% potentially of patients will get diagnosed with cancer depending on the clinic. It's a bit higher for the rapid access diagnostic clinic, but you don't have to necessarily say that. I would tell them what to expect at their clinic appointment. Obviously, that will be a bit different in times of COVID, but to tell them that they will be seeing potentially a colorectal surgeon or a colorectal clinical nurse specialist or whatever it might be. Tell them potentially what investigations they might have. You know, you don't have to know exactly what they might end up having, but at least they are aware they might end up with a CT scan or an endoscopy or whatever. So at least they've got that thought in their mind prior to being told in the clinic. As Caroline said, confirm that they're going to be around for the next 2 weeks and they're not going on holiday. And also, I think it is useful to have someone with them, either with them in the virtual appointment, just so that they can digest the information a bit more readily. And if they are going into the hospital for their appointment, if that is permitted with the COVID restrictions in place currently, that needs to be checked. The other thing that obviously you can do at your referral appointment, or you can ask your admin staff to do in surgery, is to provide the patient with the 2-week wait information leaflet at the time of referral. We know that a lot of information isn't absorbed by the patient at the appointment. That's even worse in telephone appointments. And if you add on other aspects that can make communication more difficult, such as cognitive impairment, or maybe patients whose first language isn't English, then the level of retention of information can be relatively low. So therefore, by sending them information leaflets just to reinforce and remind them what was discussed is very, very helpful. This can be shared either as a physical copy, or it can be shared as an electronic link via AccuRx, for example, which you can then text to the patient. These are available via that link on the slide there. They're also available if you click on the hyperlink on the 2-week wait form. It will take you through to that website where the information leaflet is available in English and the 11 most prevalently spoken languages in London. There's also the COVID specific 2-week wait information leaflet as well, which talks about the changes that have occurred in the 2-week wait clinics under COVID. So that's also there and can be sent as a link, or it can be printed off as a physical copy too. Thanks, Zara. Next slide. Now, I don't want to talk too much about fit tests because I know that Harriet's going to cover that in her part of the webinar, but I really wanted to talk about the provision of the information leaflets that go with the fit test. So, you know, fit is a relatively new investigation for us in primary care. So, you know, understandably, GPs may still not be necessarily familiar with how the fit test is performed. So patients are definitely not going to be familiar with how the fit test is going to be performed. So I think it's really important to provide patients, every patient you give a fit test to, print off or send the link to the fit instruction sheet, which is available on the DXS repository. That's also available in the 11 most commonly spoken languages as well. Now, we, as cancer leads in South East London, we hear about reasons for these fit tests being rejected, and there's still a significant proportion of fit tests that go into labs across the patch that are spoiled. And most commonly that might be because the lid hasn't been clicked on, there's too much stool in the bottle, so it's overflowing, it's been incorrectly labelled. Stool samples are still arriving, unfortunately, in generic stool test bottles. They might come wrapped in, you know, a Sainsbury's carrier bag with some kitchen roll wrapped around it, that kind of thing. So it's really important that the patient knows how to complete the investigation, because that's just going to lead to delays in potential diagnosis of colorectal cancer. So the other thing I suppose to talk about is a little bit like the chest x-rays. A negative fit test is good, very good at excluding colorectal cancer, but it's not very good at excluding other types of cancer that might present in a similar way. So just bear in mind when you do get a negative fit, rather than filing it and forgetting about that patient, just thinking about whether other potential abdominal malignancies need to be considered. And the last thing I would say is, you know, get a fit test out of the cupboard, have a look at it and familiarise yourself with the bottle and how it works, which I've only done in the last kind of few months. And I think that really, really helps, because it is very, very different. And I think if you're familiar with the bottle, then you're going to be much better placed to tell your patient how to do it. I think that's me there. So, oh, there's a recap, which I think probably just goes over everything that I've and Caroline have said. But I won't go through all of that, if that's all right.
It's all right, George. Thank you so much. So let's move on to Harriet. Harriet, over to you.
Hi, everybody. My name is Harriet Watson. I'm a consultant nurse in the colorectal surgical team at Guy's and St Thomas's, and also a consultant endoscopist. Yes, I work at GSTT, but the guidance that we use is very definitely South East London. So hopefully I'm speaking on behalf of the sort of 2-week wait colorectal surgical teams across our patch. We use the same process. We use the same referral form, and we have fairly similar pathways in place across all sites. So I think it sort of goes across all 3 trusts. So some of what I'm going to mention has already been brought up, so a bit of a recap for some of it, and then I'll attempt towards the end to just explain what happens to the patients if you do refer them on our pathway. So as has already been mentioned by George and Caroline, the information in terms of demographic details is so key, particularly with the majority of our patients coming via the telephone assessment clinic. So 2 telephone numbers is ideal, and all the expectations of the patients with regard to being available by the phone, etc., as Caroline mentioned. Again, the relevance of all the important clinical information around relevant comorbidities, medication, etc., the WHO status, and particularly for the telephone assessment pathway, is their social situation in terms of what support they have when we're thinking about planning investigations, particularly if it involves sedation. So we need to know if they've got anybody with them, and their ability to take the bowel prep. Sometimes if they're elderly, frail, and live on their own, it's just not appropriate. So that social situation, obviously we ask, but it's helpful if there's some clue before we speak to them about what that social situation is. One key thing that gets missed off a lot, we find, is if patients have had recent or previous lower GI investigations, particularly endoscopies, because we generally don't need to repeat an endoscopy within 2 years. So if they've had, to exclude cancer, so if they've had a recent colonoscopy, CT enema, or OGD, then it's really helpful to know that. Obviously, if they've had it in our trust, we can look that up, but if it's been elsewhere, we might not have that information. So it's really important, if possible, for that to be included. As already mentioned, but again, it's all the blood results, and please don't delay the referral if they're not available, but please do take the bloods at the very least upon referring them to us so that we can then chase them. And yes, they do need to be within 3 months. And in particular, we cannot order any lower GI investigations without renal function. So we can't prescribe bowel prep unless we've got a current EGFR, creatinine, and we can't give them IV contrast or omnipaque for the cross-sectional imaging if we don't have any current renal function. So it's really, really key that for 2-week wait referrals to lower GI team. If you've done an abdominal rectal examination, please document it. It very often gets missed. For the rectal examination, even a negative examination, just comment on that is helpful. In particular for rectal examinations, the CT enemas are performed by radiographers, and they're in theory not supposed to insert the rectal catheter unless a doctor or a trained professional has carried out a rectal examination, and that's been documented as normal. So it is so much more than just telling us that it's been done. We just need to know that it was normal, or obviously what was found if it wasn't. Thank you, Sarah. So on to the FIT. So the FIT, as George says, is a relatively new addition to the 2-week wait pathway for lower GI, and it's proving to be a huge challenge for our service. A recent audit showed us that still only about 40% of our referrals are coming through with a FIT result, and even then it's not always a numerical value. And during COVID, with our restricted capacity in endoscopy, we've had to really think carefully about how we prioritise patients in terms of urgency, and we've had to use the numerical value in order to do that. So without a FIT result at all, they instantly go down the queue to priority 4. We won't stop referring them for the procedure, but it puts them right at the bottom of the priority list. So that's why it's so important, please, to send in the FIT and to add the numerical value, not just FIT was positive. Hopefully that priority list there is self-explanatory, but do shout if there's any questions around that. We can't carry out FITs from secondary care. It's not available to us. So that's why we pester and pester and pester to try and please get the FIT done on referral. And it has to be within 4 weeks. And if it's borderline and you're not sure about the referral, we encourage a retest. So please do feel that you can, send out a second test if you're just not sure and you just think something's not right. As already alluded to, a negative FIT or a FIT under 10 is very likely to not be cancer. So I think you can relax, but yes, as George mentioned earlier, if they've still got abdominal symptoms, then either consider referral to the rapid access clinic, rapid diagnostic clinic, or to one of the other sites. Thank you. We do ask that FIT is carried out in the absence of rectal bleeding. So obviously rectal bleeding, carrying out a FIT, it's going to be positive. And we get lots of patients that come in with a highly positive FIT. Their only symptom has been heavy rectal bleeding. We know that the criteria still asks that you carry out a FIT, and sometimes that's not possible. But wherever you can, asking the patient to perform a FIT when their bleeding isn't obvious is far more helpful. We get some GPs saying that they can't carry out a FIT because the patient is housebound, elderly, frail. And actually it's those patients that the FIT is really, really helpful in, because it might be that we're putting them through an invasive procedure when in fact the FIT was normal and we could have done something else. So it's a simple stool sample. It shouldn't be a problem carrying out a FIT in patients that are housebound. It's just, obviously there are maybe potential issues getting the specimen put to them, etc. But it is really helpful in those patients. So we would encourage still to have a FIT in all patients as per the guidance. Lots of patients are told, or rather interpret, I'm sure they're not told, lots of patients interpret that the FIT is a cancer test, and they come in thinking their FIT was positive, therefore they've got bowel cancer. We do try and put that into context with them and tell them that it's to detect blood, and lots of things obviously can bleed in the bowel. It doesn't necessarily mean bowel cancer. It's just, you know, we obviously then have to explain to them the context of their positive result. And I'm sure that's probably a lost in translation issue, but it is sometimes something that just needs spelling out to them. Thank you. This is obviously the guidance from the form. When a FIT is not required is when there's obvious anal pathology, and we would still accept the patients where that's the case. All of our patients are assessed via the 2-week wait telephone assessment clinic in order to triage them for the most appropriate investigation. The patients that we see face to face are those where no amount of talking about a lower GI investigation is going to help. They need to have us to look at their bottom to assess any anal pathology that's found by the GP. So those are the only patients that don't need a FIT. But every other patient presenting with the above symptoms must have one. Thank you. So just the importance of the referral information not being on the form. I mean, it kind of sounds self-explanatory, but we have a full-time coordinator, admin coordinator for our service, and she spends a huge amount of her time chasing FIT results and blood results. It just means that she's unable to then carry out other tasks. So it is really helpful if that information is there. If we haven't got the information, the patient is still booked for a telephone assessment clinic, then often we have to rebook them, because we can't book them for their procedure if their renal function isn't at least pending. So it just means that we're doubling up on lots of our appointments. And as alluded to earlier, it does make our prioritising more difficult in terms of our endoscopy services. So it does have a significant impact. And all the things that we've talked about prior to this slide about delayed investigations, etc. So, you know, it sounds like we're stating the obvious, but it does make a big difference if all the information is there at the first attempt. We've talked about the rapid access diagnostic clinic, but just another reminder, if the patient does have a FIT below 10, but is still presenting with weight loss and other symptoms that you think may indicate a malignancy, then please do use that pathway. They are a brilliant service. I don't know if any of you have had anything to do with them, but they are so helpful. They are really touting for business. They're really keen to get their service up and running, and encourage people to use it where the patients fit the criteria, and they will do everything to help with the advice and guidance if you're not sure. So please do feel free to contact them, even if you don't feel you want to definitely refer a patient to them. And they're based in oncology. I'm sure you know that. So just a very quick explanation of what happens to patients that come via the 2-week wait pathway for lower GI. So they will, as I mentioned, come via the telephone assessment clinic. They're all booked on for a full colorectal assessment, all but obviously hands-on clinical assessment where we do a full clerking, and then we triage them for the most appropriate test. For the large majority of patients, that will be an endoscopy, and often if it's anemia, they'll get an OGD as well. And that the factors that make us decide whether or not it be an endoscopy or imaging might be related to their WHO status, their renal function, their comorbidities, their social situation, and of course their symptoms, and our assessment of their risk. So endoscopy is certainly the most common investigation that we're arranging. We're using a lot more capsule endoscopy. That's quite popular with younger patients. It does require a significant amount of bowel prep. So they have to be young and fit to have capsule, but it is quite nice for patients that don't want an invasive procedure. Particularly the panenteric one for patients that are relatively young with iron deficiency anemia. It's a really good test, but they do need to be warned that the bowel prep is even more aggressive than they have for colonoscopy, because it has to be super clean in there for the capsule to pick up any pathology. We use a lot of CT colonography, and we do use CT cap and MRI for younger patients where the risk of radiation is considered to be too great for CT, but we do have a really good GI radiology team, so we use a lot of their services for our 2-week wait patients. And then once all our patients have had their investigations, all of them will come via a virtual clinic to be assessed by a consultant. Their results will all be assessed, and that might result in a second phone call to discuss the symptoms with the patients, or if we're happy that the results are normal and the patient's symptoms are transient or have resolved, they might get discharged with a "you do not have cancer" letter. And sometimes we will organise further tests, and of course on radiology we get lots of incidentalomas and other findings that we chase up, lots of liver hemangiomas, renal cysts, etc. Lots of chest nodules, and we have a really good teams with the chest lung nodule team, that kind of thing. So we're working behind the scenes quite often to make sure these patients don't need onward referral into hospital referrals before we discharge them. I think we've mentioned all these things already, but yes, please make sure that they've been referred and that they've been referred on a suspected cancer pathway. I had a lady today who had no clue, and then she found an email in her email box saying she had a positive fit, and she became very anxious. So it's really important that they know they've been referred on a suspected cancer pathway, mainly to have cancer excluded, not necessarily that they think they've got cancer, but that we want to exclude it. That's often the case, and that they are likely to be referred for an invasive procedure, which might be colonoscopy, but even the CT colonography involves a rectal catheter, so it's important that that's part of the process. And again, being available within the 2-week wait time frame makes a massive difference. We just have to discharge them back to your care if they're not, because of the breach dates that we have to abide by. So that's really key too. Please do contact us via advice and guidance if you'd like any further information, and we're very happy to be contacted by email for advice. If not, we'd be more than happy to have an email chat or a telephone chat with anybody who would like to know more about the service or just want some advice on whether or not to refer a patient to our service or to the rapid diagnostic service.
Thank you, Harriet. And that was really interesting, and we've got some questions around this, so I'm just going to go through a couple of them, and if there are any that we can't answer, we will just take them offline. So the first one is, what would be your advice on patients for whom it is difficult to get a fit test, i.e. housebound, or difficulty providing an adequate sample? Does anyone want to answer that? Oh, thanks.
I mean, yeah, so I alluded to that earlier. I mean, it is really important for those patients to still have the fit, because those are the patients that we don't want to bring into hospital for an unnecessary procedure. I mean, it may be that they need some assistance with it, with the district nursing team, etc. But it is certainly really important that those patients don't still have the fit carried out. So yeah, we would still encourage it to be done on those patients.
Great, thank you. And is there a pathway to send photographs of suspected skin cancers along with history for 2-week wait assessment? George and Caroline, do you know?
Well, you can, sorry, Caroline, to jump in. You can definitely send photographs via the Consultant Connect app to a consultant dermatologist who would be able to give you advice whether that would, whether they feel that an urgent suspected skin cancer referral should be performed. And I've definitely done it that way. And the response is obviously very quick through Consultant Connect. So that's what I would suggest. I don't know if you suggest something else, Caroline.
No, I don't think there's a sort of particular 2-week wait photograph assessment, but as George said, Consultant Connect via the app is a possibility.
Thank you. And we've been asked, how sensitive is the fit? If negative, then does that mean that the patient doesn't need an endoscopy unless symptoms are very concerning?
I would say it means they don't need an endoscopy. They don't need a 2-week wait referral. It doesn't mean they don't need an endoscopy, but if the fit is negative, that means it's very unlikely they have bowel cancer. But it doesn't mean they don't need referring. They just don't need a 2-week wait referral. So they could still be referred to our routine TAC and still have an endoscopy or GI investigations on the routine pathway. So please do still refer them. We wouldn't not investigate them. It just means they don't need investigating urgently. Does that answer your question?
Thank you, Harriet. What we can do is we will take these questions offline as well and answer them, because there's another, and we can give you links which will provide further information and further support, and also further information around the Rapid Access Diagnostic Clinic, because that was touched upon around what happens with a negative fit. I think we have answered all of the questions. If there isn't anything else we want to discuss, I'd just like to thank everyone, all of our panelists. I think this afternoon has been really useful. We will upload the webinar onto our YouTube channel, and we will also send out a link to you all asking you to complete the evaluation form, and then you'll get your certificate of attendance. So if there isn't anything else, I'd like to thank you all and take care. Have a nice rest of the day.
Thank you.
Thanks so much, guys. Bye-bye.